Good morning all. After this informative talk, I welcome Dr. Rekha PS to talk on orbital mucormycosis. She is currently working as Associate Professor in Government Medical College, Manjeri.
Good morning, everybody. First of all, I would like to thank KSOS and Rajini Madam for giving me this opportunity. There has been a rapid increase in the incidence of mucormycosis in the recent past during our COVID-19 second wave. So in this presentation, I would like to summarize what we have learned from our experience and from the literature. So we all know that it is caused by the fungi Mucormycosis, and it is a potentially lethal angio-invasive fungal infection. There are many risk factors. Apart from COVID-19, we have diabetes, uncontrolled diabetes, patient on long-term steroids, patient on immunosuppressive drugs, primary or secondary immunodeficiency, and other malignancies. There are many red flags of rhino-orbitocerebral mucormycosis. That is, periorbital or facial edema, facial pain, worsening of headache, sudden onset of proptosis, sudden loss of vision, facial paresthesia, sudden ptosis, and ocular motility restriction. If patients with any of these risk factors develop these red flags, we should think of mucormycosis. Now regarding the diagnosis, if the patient develops symptoms and signs of mucormycosis with a predisposing factor, it is known as, it is called possible mucormycosis. We don't have any supportive diagnosis, But if there is a clinical signs and symptoms along with a positive nasal endoscopy finding or a MRI finding, we call it a probable mucormycosis. And clinico-radiological features along with microbiological confirmation, it is known as proven mucormycosis. Now coming to the staging, mucormycosis enters the human body through the nasal mucosa. So stage 1 means it is involvement of the nasal mucosa alone. And if it spreads little further, that is stage 2 means it is involvement of the paranasal sinuses. And in stage 3, orbit is involved, and in stage 4 there is involvement of the central nervous system. And this is according to the article published in IGO by Dr. Santoshanava. So stage 3 in detail, it is involvement of the orbit. It is subdivided into 4, that is 3A and 3B. Vision is not affected. And there is a limited orbital involvement. The whole of the orbit is not involved. In 3C, there is loss of vision mainly due to arterial occlusions, and 3D, there is a bilateral orbital involvement. Now we'll move on to the management. It depends on the stage of the disease. So definitive step will be induction with full dose liposomal amphotericin B. There are other alternatives which are cheaper but has lower efficacy and higher systemic toxicity. Now if it is a possible mucormycosis, that is there is no supportive evidence by nasal endoscopy or MRI, we can closely observe the patient, start supportive therapy, and then we'll repeat the endoscopy and MRI. And if, after repetition, if we get a positive finding, then we'll classify it as probable mucormycosis. And even if in repeat investigation there is no positive finding, it is unlikely to be mucormycosis. In probable and proven case of mucormycosis, we can start with intravenous liposomal amphotericin B, 5 to 10 milligram per kilogram. And there are certain procedures that we have given, that is transcutaneous retrobulbar injection of amphotericin B and orbital excineration. So TRAM, that is indicated only in limited involvement of the orbit and vision is unaffected. Only in such stages we'll give transcutaneous retrobulbar injection of amphotericin B, that is stages 3A and 3B. Here 1 cc of 3.5 milligram per ml, that is the dose. We have to reconstitute the amphotericin B to get a concentration of 3.5 milligram per ml, and it should be repeated on alternate days, and site of injection can be varied according to the imaging. Orbital excineration is indicated only if there is complete vision loss and total ophthalmoplegia, and if you feel that it is not responding to our intravenous antifungal therapy, if there is a diffuse involvement of the orbit including the apex with no visual potential. In such cases only we'll move on to orbital excineration. Now the question is whether it is effective or not. So many studies have shown that TRAM is an effective method in mild to moderate, that is limited orbital disease, but it is not a replacement for orbital excineration. But certain other studies have questioned That is, they have shown that many clinicians have shown that it is not of much use, and also there is no clarity regarding the number of injections, the optimal dose, or whether there are any side effects. So more and more studies are required to consider it as a treatment modality. So that's all for today. Thank you.